Welcome to the Pharmacists Are In, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
Welcome back, everyone, to another episode of the Pharmacists Are In podcast. My name is Ajit Johal. I'm based out of Vancouver, BC, and I'm joined by my colleague and friend, Dr. John Papastergiou. John, how are you today?
Good, buddy. Good. I feel like it's been a while since I saw you. We're coming off an episode with a celebrity, which was pretty exciting, and then I think you were off. You made it to FIP this year, no? I think you were in Copenhagen. I wanted to get out there, but I never got a chance.
Yeah, so it was in Copenhagen, Denmark, for the FIP conference, the FIP Congress, the Federation of International Pharmaceutical Association. I think that's what it's called. I always get it wrong, but
yeah,
FIP.
It's complicated, but yeah, it's everyone calls it FIP, but it's one of those conferences. I didn't really learn about it until a little bit later in my career, and I started going out. But it for me, it really is about getting those countries where pharmacy is evolving or moving forward quickly, and they don't have their own professional associations or big professional associations. And I find Canadians, we've always been lucky where we've had pretty good representation from groups where. So it's not a big conference for Canadians. That's what I was getting at there.
Yeah, there was a pretty, I think relatively speaking, there's a lot of international attendees for sure. There was a pretty good contingency of Canadians. So there was a reception on one of the days, so Canadian reception. I think it was through CPHA. And it was good to see some colleagues there. And I think the main thing is the Canadian attendees typically have some sort of poster or publish practice-based research, and it's quite remarkable how advanced Canadian pharmacy is. So that I think that is one of the challenges for FIP is so much heterogeneity in our profession of pharmacists, right? So it's like different jurisdictions around the world are at different sort of points in their journey of how much they can contribute to primary care, and Canada seems to be one that's really leading the way. So makes a lot of sense that there'll be a big Canadian contingency and showcase in Montreal in 2026. But
yeah, that's big. When was the last one? I think Vancouver was the last FIP in Canada, but I don't remember it. It must have been ages ago, no?
Yeah, before my time probably.
It was a long time ago. So it's going to be good to showcase Canadian practice. I mean, I've gone through quite a few of them over the years, and I find it's if you're a Canadian there, you're right. You're either presenting or you've got some type of poster or whatnot. And you could tell by the quality of the Canadian work, it is quite more advanced than some of the other countries. And everyone's trying to kind of move forward. It's just they're at different parts. Like you'll go there and you'll see talks about fake drugs, which applies to some parts of the world and this and that. So it really is a global conference. And I'm always amazed at the organizational skill to get this thing off the ground. They've got like a lot of people behind the scenes trying to get this thing organized and efficient. It's over the course of quite a few days too. It's not a short conference, almost a week, I think, right? So
almost a week, yeah. It's a couple days, and you're right. The organization is really top notch. There's some great volunteers from the pharmacy school in Denmark helping with registration and navigation. And the one thing actually is the transit system in Denmark is phenomenal. So there was a green pass sponsored by Haleon, where attendees had access to metro and things like that. And that's how I got to the conference, is just the metro works really well.
It's awesome. That's a good idea, actually. I would have liked, I've never been to Denmark. I would have liked to get out there and just kind of see. I mean, I did my PhD in the Netherlands, so I'm always interested in European practice and what's going on. And there is quite a bit of variation all across Europe. But you were presenting a couple of posters, I think I saw.
Yeah, so it was one poster on, basically it was a retrospective chart review or pharmacy review of all the vaccines we've done, pharmacist initiated, so pharmacists as the prescriber, since 2018. So 2018 to 2024, so a 6-year review, over 100,000 vaccines given, and over, I'd probably say 90% of them were COVID and flu just by volume, but there were some really impressive antigens in there as well, like RSV. So RSV vaccination, there was sort of a bar chart we had of all the RSV vaccines we did as pharmacist initiated. And that actually came from the 2023 fall season when RSV was launched. So
Okay.
RSV was launched. It was a new vaccine for an age-old disease, and we'll kind of talk about how we need to bring this back to the forefront, because RSV is a serious player as we get into, we're basically just climbing right to the start of respiratory season. Here we are just recording here in early October. But we did a phenomenal amount of pharmacist initiated, because a lot of the primary care prescribers, as you know, weren't aware of the burden of disease, weren't aware of the vaccination, and patients were actually coming in because there was some direct to consumer advertising to the pharmacy, right? If they get their COVID and their flu shots, then they're going to ask about this other one, right? Because typically they're in that demographic that would benefit. So we actually published a poster at CIC in 2024, which showed that 85% of over almost 300 RSV vaccines we did in that one season were pharmacist initiated. And a lot of those patients were from a household. So a lot of people, even if their doctor did prescribe it, their partner or spouse is not part of that clinic, so helping them getting a vaccine as well. And a lot of these patients were also up to date on their other vaccines, like pneumococcal, which we'll talk about in the next episode. So it really showcases the access point, and we talk about this ad nauseum, of being independently able to recommend any vaccine facilitates access and will improve vaccination rates. And we showcase that for multiple antigens at FIP. So our goal is, when attendees came from various countries, all the way from Norway to Italy and South America, was telling them, hey, listen, like, this is what is possible just from 3 pharmacies in a single province in a country that allows this, right? So over 100,000. So it just shows that the level you can get to with travel immunization, vaccines that are recently approved. If you as a pharmacist have the scope to do it independently, then that really drives access for sure, and obviously increases immunization rates. So that was sort of the goal. And obviously everyone at the conference is at different stages in their various countries with that scope, but it's good to show that, this is what the best in the world looks like, and what to aspire to. And even in Ontario, I noticed there's some new legislation coming through or up for review. It'd be great if you had the same scope there, because I'm sure, if somebody wants an RSV vaccine, you have no issues providing it, but your hands are tied with various legislation.
Yeah, see, this is a couple of points here. First of all, that's an incredible number, because initially when you said 100,000, I wasn't sure where you got the data, and when you highlight it's 3 stores, man, that's an impressive number to talk about the impact you guys are having out there. And I gave a talk with a speaker maybe 2 weeks ago out of Alberta, and that's one of the things we spoke about. When you look at RSV initiation in Alberta, for example, it's really high. Almost all of it's being done by pharmacies, where it's not possible here in Ontario, right? So our initiation rates are very low, because you still got to contact the prescriber and all this stuff, unfortunately. And hopefully this new scope and the availability of public vaccines and whatnot is really going to help move this forward in Ontario, because it's such a lost opportunity for us here, having all these pharmacies that are very good at immunizing now, but still we're limited for certain therapeutic areas, right? I'd love to get beyond that, and hopefully it's coming. But that's one of the big differences between when we talk about RSV, between Ontario and Alberta and BC, and it's had New Brunswick. How do we get there, right?
Totally, yeah. And I think, you do presentations on RSV. You've been doing that since probably the summer. I've been doing some presentations as well. So one of the things we always start with is the burden of disease, right? So there is a study that actually, when healthcare professionals were asked about would they prioritize RSV, it's typically not as much of a priority in their conversations, probably because it's not as, historically we haven't had any prevention, we don't have any treatment, and we don't do a lot of testing. So if we look at those three things, obviously with treatment, with these viral illnesses, it is challenging. But with prevention, look what we have now. We have maternal immunization, we have monoclonal antibodies, and we have 2 vaccines for older adults. So in the span of 2 years, we have seen multiple options to protect our high-risk patients across the lifespan, the very young and older adults. So I think this needs to be put top of mind. We also need to draw our attention to what respiratory season looks like now, because there are really 3 key diseases we're looking at: viral illnesses, viral respiratory illnesses, and I would argue pneumococcal deserves its own episode, which it will get if you stay tuned for the next episode. But a couple of links in the show notes, which I think would be helpful for our listeners, is some of the ways Health Canada and Public Health are monitoring respiratory season, because historically it was always flu watch and it was always influenza-like illness. So it's like ILI, it could be anything, but now they're very targeted. So they're actually doing testing in the hospital, which you're the guru on testing in the community. It'd be great to get this testing in the community because you would pick up a lot more. But as a proxy for that, so what's happening is over respiratory week, there's going to be reported positive test percentages for those who are hospitalized for any sort of respiratory illness. Right now, COVID is dominating the scene since September, and I'm sure you've seen a lot of COVID cases in your own practice. And I'm sure we'll see influenza and RSV pick up later on. But the other thing they're looking at is wastewater. So just like what we do in developing countries to look at polio, for example, in the wastewater, looking at COVID, flu, and RSV. And once we see RSV high in the wastewater, that is often a potential marker or sign that there's high transmission in the community. But obviously having these point of care tests to see if what specific pathogen they have, there's a lot more for antibiotic stewardship, but also to make patients more aware that this is a real illness. Because like, how many times do you have people say, oh, I was super sick? If we knew what that was, they would tell everyone who's at risk and who's eligible, because that word of mouth is so powerful. So I really think we should ideally move to community testing in pharmacies. But what we can do now is we can talk about immunization.
Yeah, and you hit on some of the work that I'm doing right now, and I don't think I've talked to you about this, but I have a research student right now looking at this. So we have NAP PCRs in my pharmacies, right? So we're able to look at what the underlying cause is. We have to swab and whatnot, but it's pretty interesting because I have a student now swabbing patients that come in with respiratory illness that have been prescribed an antibiotic. So we're looking at 2 things: what's the causative agent, and then also if an antibiotic was appropriate. But it's always surprising to see what's circulating, right? So when we're doing this test, so you see it might be influenza, all of a sudden it switches and it's RSV. And I think, we just kind of group it all together. We think it's a cold or whatnot. But you can really, when you're testing, and we're so ideally suited to do this out of the community, and I really believe as this technology evolves, gets cheaper, it's more widely accessible, we'll play a huge role in surveillance. But yeah, you can see just when RSV is circulating, it's almost every test, that comes up. And we've got a couple of years of data right now. So I think this will be an interesting paper when it comes out. But yeah, I push for this a lot. But obviously, there's got to be reimbursement. I mean, these tests are still not super cheap. I mean, they're getting quite a bit cheaper, but there's no real reimbursement. So if you're not doing it under kind of the guise of research, or patients are willing to pay. Sometimes they're willing to pay just because they want a sick note for influenza or something, and they'll dish out for a test, but there's not a good system in place as of yet. But as we're on that topic of RSV, some things have changed with the guidance and the monographs, and I know our listeners are always interested in this stuff. So give us a super high-level summary, like what are those therapeutic pearls, what's come back out of in those monographs and in the guidance around RSV. I think you always do a great job just summarizing it for everyone.
Yeah, for sure. So basically, as I was mentioning, there's options across the lifespan. So when you look at infants in their first year of life, that is probably the most common cause of hospitalization in terms of sheer volume of what communities see for RSV. So there's two options. One is maternal vaccination with the product Abrysvo. So there's, as I mentioned, there's two for older adults. One of them is also for pregnant women as well. Typically done at 32 to 36 weeks gestation. So that is the optimal time to make sure the baby is getting close to term. We don't have any issues with prematurity. There was a potential signal in the Matisse trial about early RSV vaccination administration in premature birth, but it's hard to discern if that was the actual causation because a lot of it was done in developing countries. So it's tough to say if it's above baseline risk. But that being said, just to be on the safe side, we always want pregnancies to go north of 30 weeks. So 32 to 36 weeks is the window. Often that's a time when the pregnant woman would get pertussis vaccination as well. Monoclonal antibodies are done when the baby's born, and that provides antibodies directly to the infant. So that is something, for example, Nursivimab is what Ontario has done for all infants. Actually, it's an option available for all infants to basically get that protection in their first year of life when their lungs are really small, and that's when the risk is the highest. We're going to focus more on older adults because I think this is where pharmacists play a big role, because a lot of those patients who are, the product monograph says 60 and over, that was recently updated for 50 to 59 with at least one chronic medical condition, and that's chronic lung, chronic heart, etc. Because we know that people who are 50 with a comorbidity are probably more at risk for severe disease and hospitalization than those who are 60 and don't have those comorbidities. So NACI, with their updated older adult statement, which we have posted in our show notes, basically says that 60 and over is the product monograph, and then 50 to 59 you can use Arexvy, the adjuvanted product. So that product monograph has been updated. So basically for older adults, 60 and over, Abrysvo or Arexvy. Now there's no head-to-head, so either option is good and is appropriate. And then for those 50 to 59 at this time, again, these are always changing, then it would be Arexvy. Currently has the data that was submitted to Health Canada. So I think from a pharmacist perspective, there's also another layer, because NACI is also recommended for 75 and older, especially those with comorbidities. And most Canadians who are 75 and older probably have at least one medication they're taking from the pharmacy, is there should be a public program. And I think, John, this is the first season that Ontario is doing their public program for community dwelling, 75 and older, and then 60 and over in long-term care. So those two populations, NACI says there should be a public program, and Ontario and other jurisdictions have adopted that, like Alberta. BC has not at this time. For those 60 and over or 50 to 59 who are not in long-term care, but would like to have the protection from RSV, and again, these were individuals included in the trial. They shows that the data, well, 60 and over were included in the trial, and the 50 to 59, there's good immunogenicity data. Through shared clinical decision-making, this is something that could be recommended for them. So there's a lot of opportunity, I think, in pharmacy to talk about this, especially as we get into this respiratory season. RSV is a big player. When we look at burden of disease, just like COVID or flu, it can cause the destabilization of chronic disease. So sugars get out of whack, kidneys get function declines. When we look at the data, actually the risk of secondary pneumonia is higher from RSV than it is from flu. We also know that the mortality for individuals who are older and are hospitalized with COPD are significantly higher than children. And in fact, up to 1 in 9 will not make it out of hospital. And if they do, they lose activities of daily living. So this is an important conversation to have. I think it should be part of chronic disease management. I think it should be part of flu conversations, COVID conversations. It's a respiratory pathogen that is just as capable of inflicting damage.
Yeah, as I think about kind of the workflow right now in the community pharmacy, we've got here in Ontario, we've got COVID vaccine available, not flu yet, but it's coming. And I've noticed, I mean, we do a super high volume of immunization, and I've noticed this year in particular, it's been a slow start to COVID. So, I'm not sure if it's patients waiting for flu, and we do a lot of co-administration as well. Are they just waiting to come in? Either way, this opportunity right now occurs like once a year. You get them in there during the consent process or whatever, ask them about other vaccines, because many of them just don't know that they're eligible. We see that in the data all the time. If you make that recommendation, it won't be all of them, but you'll be a percentage of them that will consider getting vaccinated or get vaccinated, right? So I think that's where we have a huge opportunity. The other thing I wanted to talk to you about briefly was, what's going on with, the vaccine effectiveness as we go along here. So there's always these questions I get around boosters and whatnot. So what have you seen in the data with respect to the drop off? Are we gonna need a booster? Anything yet? Because it seems like I'm getting some mixed messages there.
Yeah, that's a good question, John. I think a lot of patients want to know, especially whether they get it publicly funded or if they pay out of pocket, is the durability of protection. So at this time of October 2025, there's no recommendation for a booster. We've seen through the different products through the randomized controlled trials that the protection stays pretty steady as we go through each subsequent RSV season. So it seems like the vaccine is working quite well and is quite durable. Now, obviously, that could change, but at this time, we basically say the best thing to say is there's no booster recommended at this time. And you always add the "at this time" because you just never know, right? And especially for these respiratory sort of diseases, especially the mucosal and all that stuff, we do see that wane, and that's why we get a flu shot every year. And for those who are at high risk, get a COVID shot every 6 months. But for the RSV vaccine, it is showing that durability, which is great. And that's for both products, both the Abrysvo and the Arexvy.
Yeah, it's important, especially, when patients are paying out of pocket for a vaccine. That's something they do ask, Is it something I've got to get again? Is it something I've got to get every year, right? So being able to answer that question, I think, honestly, based on the best available evidence is super important. Have you guys seen that same trend, though, in BC? Like, are you guys doing COVID vaccine now, or?
No, so we're starting after Thanksgiving. So our official start date is always typically the Tuesday after Thanksgiving. So I think we'll definitely see. One thing we're doing here in BC is with RSV vaccination. Ideally, it should be done before the start of RSV season, and according to Flu Watch, or including to our the respiratory dashboard, I shouldn't call it Flu Watch anymore because it's more inclusive of other diseases. Is it hasn't. So it's a great time now that we're providing the vaccine before the rush and the onslaught. Because I agree with you, John, we should mention other vaccines and talk about it, but a lot of times to actually pull it out, take payment when there's that lineup, and I know you do a lot, they're lined up around the block, so that is disruptive to your workflow. One thing I will note is that NACI is very, very favorable for co-administration of respiratory vaccinations. So COVID, flu, and RSV, whether it's Abrysvo or Arexvy, can certainly be given on the same day. And I know Public Health Ontario was doing a bit of a spacing, a 6-week spacing or something. That completely out the window. I think we should take the opportunity. So a lot of them we're doing now as we went from August, September. You can co-administer it, or the patient can come back. So it's really whatever works best for your workflow and when the patient can come back with the vaccines.
Yeah, and this is an important point. You touched upon it with respect to operational considerations. That's why I said, ask during the consent process, because if you're waiting till that patient's in the pharmacy, in the room with the pharmacist getting their vaccine, and I happen to ask, hey, do you want, COVID with this or flu or whatever they're getting, right?
Yeah.
Now, if they say yes, that's right back to the front, reprocess it. All the amount of extra work that it creates when you're doing the high volume vaccines it's really problematic. So we do spend a lot of time thinking about, okay, what's the operational workflow here? What are we going to ask at drop off? And what can we get the patient to commit to there before they get into the room? Because a lot of times the pharmacist could easily convince them, but now you've created double the work, or the administrative work anyways. To give the vaccines is very quick, but administration is a huge part of this.
Yeah, the additional issue of needing a prescription, right?
For sure.
Alone. So I think realistically, a realistic sort of tip for pharmacists as we get into flu and COVID season, where a lot of them will be co-administering flu and COVID, is just to mention RSV as another player in this dance, right? So it's like, if you mention it, especially if you're patients who are getting high dose or adjuvanted flu shots, right? So they're typically over 65 and often they're taking multiple medications. They could be your blister pack patients, is to, ask them to seriously look into their RSV vaccination status, which is another challenge you have in Ontario without that central registry. So we won't go there, but I think instead of making excuses, let's focus on having results. And I think pharmacists across the country can do their patients a huge favor by just bringing this up, because that lack of awareness from a healthcare professional is the first lead domino to getting them closer to being protected.
Oh, for sure. And when you think about who you get in there early in the season, obviously it's the seniors, but it's the at-risk patients, the COPDers, lung disease, hypertension, diabetes, chronic kidney disease. Those guys are coming in first, right?
Yeah.
They're hyper aware of it. Everyone's told them, hey, you're at risk, get in there. So when you get that type of patient, they're much, much more likely to accept your recommendation for these other respiratory vaccines. So really try to capitalize on that early in the season. But I'm aware of the time here. Last thought, we're going into the crazy period right now. So if you've got a couple of tips for pharmacists nationally, what would that be in a nutshell?
I would just say, just be realistic in terms of your bandwidth. I know that staffing is a challenge. I know a lot of pharmacists will be working long hours. I've heard from colleagues that they often start as early as 6 a.m. to get 2 hours in before, again, another issue, the fax machine starts going, right? And they often stay later. So I think the first 2 to 4 weeks of respiratory vaccination season is very busy. So take the time to pace yourself. Me and John don't want to come in and say, hey, talk about this. Yeah. Just keep doing the great job you're doing and just be comprehensive and when you're talking about flu, COVID, and RSV. And I would also say pneumococcal as well when we talk about the next episode. But don't feel obligated that you have to administer these and be on the hook to close the loop in the next 2 to 4 weeks. But just having that conversation, I think, will make a huge difference.
Yeah, that's great. Great advice. So I think with that, on that note, we're going to wrap up this segment. We'll be back with a segment on pneumococcal disease shortly. It's great talking to you, Ajit.
You too, John. Always a pleasure.